damage of olfactory mucosa. Olfactory dysfunction affects 3 to 20% of general population, with 1/3 coming from viral upper respiratory infections. COVID-19 accounts for over 80% of these cases, and 7% of patients experienced persistent hemophobia. Increasing evidence suggests that COVID-19 related olfactory alterations are secondary to damage to olfactory mucosa, and not the olfactory nerve itself. This means that by treating the olfactory mucosa, you can address the nodule. Most affected cells are non-neuronal, such as sporin, basal, and thrombus cells. We use the MIH classification from 1988, still nowadays working, and the majority of our patients stands in stage 3 and 4, which means that they have a functional nerve, but with a natural frequent mucosa. So, Fausto Viterbo in 2018 came with the idea of treating anosmia with nerve pressures, but we made 3 major changes: end-to-end neurophy between the sural nerve graft and the supraorbital nerve, the removal of the epineuron from the terminal part of the sural nerve graft, which enhanced the surface area, and the positioning endoscopically in an area with a large amount of olfactory neurophilia. So, the main idea here is the presence of a lead nerve graft that enables the regeneration of the olfactory mucosa. However, this does not mean that the presence of the newly connected nerve with the supraorbital nerve will conduct the stimuli, as it would require a special type of stimulus. So, here's the study design prospective cohort. Our objectives are evaluate changes in the olfactory neurophilia of patients with olfactory disorders and correlate them with the response after nerve pressure surgery. Since 2022, we have 12 patients. Our inclusion criteria was persistent olfactory disorders, clinical treatment lasting more than 6 months, regardless of radiology, and all patients have to pass through this rapid olfactory test from Connecticut Chemosensory Clinical Research Center before surgery and every 3 months after surgery. And exclusion criteria is just probabilities that could affect the results. So, the first 2 incisions are made bilaterally, exposing the supraorbital nerve and the nasal pyramid, through which a cutting drill will create a passage for the sural nerve graft into the nasal cavity. Here, now we have the sural nerve graft. We did a segment measuring between 15 to 18% centimeters, and we prepared the terminal part by removing the epineuron to increase the surface area. So, end-to-end neurophy between the supraorbital nerve and the sural nerve graft is made. A submucosal tunnel is created using an endoscopic approach, and the nerve is positioned at the posterior part of the superior concha, which is the area with the higher connections of olfactory neurophilia, higher concentration of neurophilia, And our results, improvement was observed in 2/3 of our patients, and this number would have been higher, around 75%, but one of the patients contracted COVID-19 2 months after the surgery. So, yeah. Thank you for your time.